The fifth cranial nerve, the trigeminal nerve, has both sensory and motor components and also has associated reflexes that should be tested. The nerve itself provides sensation to the face, mouth and part of the dura and has motor innervations to the muscles of the jaw involved in mastication. There are also two reflexes, the afferent corneal reflex and the jaw reflex. The nerve divides into three key branches, V1, V2 and V3, the ophthalmic, maxillary and mandibular divisions. The motor components innervate the muscles of mastication predominantly via V3. The muscles include the temporalis, the masseter, the medial and lateral pterygoids, as well as the tensor tympani, the tensor veli palatini, the mylohyoid and the digastric muscles. The pathology in trigeminal nerve dysfunction for the motor components would include weakness and wasting of the muscles of mastication. To examine this component, inspect the muscles of mastication, palpate the muscles including the temporalis and the masseter, the pterygoids and the temporal muscles to inspect the muscle bulk. Early signs of wasting could suggest disease. Ask the patient to open their mouth against resistance and then to move their jaw from right to left against resistance and to clench their teeth. The sensory component, remember that the sensation from the trigeminal nerve supplies the face, the scalp, the cornea, the nasal and oral cavity as well as the cranial dura mater. V1, or the ophthalmic division, leaves the skull via the superior orbital fissure to supply the skin of the upper nose, upper eyelid, forehead and scalp, as well as the sensation to the cornea and conjunctiva. Any loss of sensation here could indicate damage to V1. V2 leaves the skull via the foramen rotundum and provides sensation to the maxillary region, whereas V3 leaves the skull via the foramen ovale and supplies sensation to the floor of the mouth, sensation but not taste in the anterior two-thirds of the tongue, as well as the mucosa of the cheek and the temporomandibular joint. Pathologically, any damage to the superior orbital fissure as a result of cancer can result in loss of sensation in the V1 distribution as well as loss of the corneal reflex. Damage to V2 or V3 can lead to loss of sensation in the associated sensory regions, and this may occur as a result of facial fractures or injury. In order to examine the sensory components, compare left and right. V1 or the ophthalmic division can be tested by innervating the forehead or the anterior scalp, V2 by testing sensation over the cheeks, and V3 by assessing sensation over the jaw. An orange stick may also be used to assess the sensation of the anterior two-thirds of the tongue to ask the patient whether or not they can detect the sensation of touch on the tongue. There are also two key reflexes. The corneal reflex, particularly the afferent fibers from the trigeminal nerve, and the efferent response is from the facial nerve. A loss of the corneal reflex may indicate afferent trigeminal loss or efferent facial nerve damage, and the jaw jerk. A normal response is no or minimal jaw closure. A brisk jaw jerk is seen with bilateral upper motor neuron lesions in the pons. In order to examine the trigeminal reflexes, the corneal reflex gently touches the edge of the cornea using a wisp of cotton. In healthy individuals, both direct and consensual blinking occurs. The absence of this blinking response suggests pathology either in the trigeminal or facial nerve, and the jaw jerk involves it's very lightly tapping over the lower part of the chin, and an exaggerated response, an exaggerated closure would suggest an upper motor neuron lesion. In summary, the checklist for the trigeminal nerve is to assess sensation in the forehead, cheek and lower jaw, assess and inspect the muscles of mastication, assess the jaw jerk and the corneal reflex. Thank you for attending this medicine masterclass.